안녕하세요. 6개월차 신규 간호사 애나에요. 이 채널에는 저의 일상과 간호사로서 성장 과정을 담아보려 하는데 오늘은 6개월 차가 된 지금 인계를 어떤 식으로 하고 있는지 기록해 보려고 해요. 앞으로 시청하시는 모든 분들과 같이 성장해 나가면 좋을 것 같아요. 그럼 바로 시작할게요.
So we'll start with bed space 4. Patient XYZ, 58-year-old male, full code, CTS patient, allergic to sulfa and penicillin. 5'8", he came in for CABG ×1 with mechanical AVR with Dr. A. He was discharged on the 18th with misjournal infection that the team was aware of at the time. 6/12, he completed his course of doxycycline and Caflex outpatient. 6/14, he was readmitted for persistent misjournal infection. 6/15, he did debridement and also the chest washout, and the misjournal wound is connected to wound vac for negative 125 suction. 6/16, which is today, Foley was discontinued around 1700, so check if the patient voids by 2300. Oh, and the wound vac dressing changes due Tuesday, Thursday, Saturday schedule. So one was done by the team yesterday, you would have to change it tomorrow. History-wise, he's type 2 diabetic, aortic stenosis, arthritis, depression, GERD, hypertension, hyperlipidemia. He's currently sinus rhythm on tele, 70s to 80s heart rate. IV axis, we have right forearm 20, right hand 16, right AC 16. He's ACHS, AccuCheck, up at live, carb control diet with no fluid restriction. The only skin issue we have with him is misjournal incision that's connected to wound vac. He takes Dilaudid, 4 milligram Q6 for his pain. He doesn't take Tylenol. It doesn't do anything for him. Dilaudid was given at 1400, so you will be able to bring it in with your night meds. He takes Q4 oxycillin IV, so we're planning to put a PICC line in him before he gets discharged so he can continue his IV antibiotics at home. Any questions? So we'll start with bed space 4. Patient XYZ, 58-year-old male, full code, CTS patient, allergic to sulfa and penicillin. 5'8", he came in for CABG ×1 with mechanical AVR with Dr. A. He was discharged on the 18th with misjournal infection that the team was aware of at the time. 6/12, he completed his course of doxycycline and Caflex outpatient. 6/14, he was readmitted for persistent misjournal infection. 6/15, he did debridement and also the chest washout, and the misjournal wound is connected to wound vac for negative 125 suction. 6/16, which is today, Foley was discontinued around 1700, so check if the patient voids by 2300. Oh, and the wound vac dressing changes due Tuesday, Thursday, Saturday schedule. So one was done by the team yesterday, you would have to change it tomorrow. History-wise, he's type 2 diabetic, aortic stenosis, arthritis, depression, GERD, hypertension, hyperlipidemia. He's currently sinus rhythm on tele, 70s to 80s heart rate. IV axis, we have right forearm 20, right hand 16, right AC 16. He's ACHS, AccuCheck, up at live, carb control diet with no fluid restriction. The only skin issue we have with him is misjournal incision that's connected to wound vac. He takes Dilaudid, 4 milligram Q6 for his pain. He doesn't take Tylenol. It doesn't do anything for him. Dilaudid was given at 1400, so you will be able to bring it in with your night meds. He takes Q4 oxycillin IV, so we're planning to put a PICC line in him before he gets discharged so he can continue his IV antibiotics at home. Any questions? So next is bed space 3, patient ABC, 73-year-old female, heart failure, CTS patient, full code, and allergic to aspirin and codeine. So 5'8", she came through ED with shortness of breath and bilateral lower extremity edema. She had moderate mitral regurgitation and severe mitral stenosis. 5'13", she did MV replacement, TV replacement, and CABG times 3. 5'16", she came down to our unit. 5'17", she went into AFib RVR. Heart rate was in 160s at the highest. Patient was asymptomatic. We hung 2 grams of mag and amio drip, and she converted back to sinus rhythm on the same day. 5:20, she went back into AFib, and the team was concerned of anticoagulation, so they started her on heparin drip. Heparin is running at 1,200 units per hour, range is 49 to 67. She's therapeutics times 1 right now. Next PT-TAC draw is at 1,700, and I put the order in already. History-wise, she has hypertension, hyperlipidemia, type 2 diabetic, chronic anemia, ex-smoker, and OSA. So morning lab was drawn, but CBC hasn't resulted. Hemoglobin was 7.3 yesterday, and it's been trending down for a couple of days, so I have a feeling that it might be lower than 7. There's an order for 1 unit of PET red blood cell if hemoglobin is below 7, so just watch out for that. Type and screen is up to date, so you don't have to worry about that. Her rhythm is AFib controlled on tele. She's on 2 liters of oxygen, nasal cannula. She was setting just fine, 94, 95 throughout the night, but she has OSA, so I didn't want to take her down to 1. IV-wise, she has left forearm 22, left AC 20, ACHS AccuCheck. She's up with minimal assist, heart healthy 4 gram, 1,500 full restriction. Her potassium was a little low, 3.8. I covered her with 20, and recheck I put in for 1,700. Skin-wise, she has that mid-sternal incision and chest tube sites, but everything is open to air. Plan for her, we're trying to wean her off of oxygen and either bridge her to Coumadin or Eliquis because of that persistent AFib. It's really up to the team's decision. If she has to be on Coumadin, she'll stay for a little longer. Eliquis, she might get discharged soon. Any questions?
Nope.
그리고 이렇게 3명에서 5명 사이의 환자들 인계를 다 다음 간호사에게 주고 나면 드디어 집에 갈 수 있습니다. 아직 6개월밖에 안 돼서 그런지 병원을 나설 때 항상 마음이 좀 찝찝한 건 저만 그런 건가요? 오늘도 마지막까지 시청해주셔서 감사합니다. 오늘도 좋은 하루 되세요.